Hi friends, welcome to a new topic in critical care medicine. This important topic, that is how to ventilate a patients of hypercapnic respiratory failure, especially in COPD. This is important topic and last topic. So I'll discuss in two parts. In first part, I'll discuss how to use NIV or non-invasive mechanical ventilation in these type of patients. In part two, I'll discuss about how to apply invasive mechanical ventilation in this type of patients. So this is important topic. So I'll discuss in a real case scenario. So as we know, respiratory system has two main function. One is oxygenation from environment to lung and removal of carbon dioxide from lungs to environment. So failure of any of these two function is called respiratory failure. Means our respiratory system is not able to oxygenate the body tissues or is not able to remove carbon dioxide from mixed venous blood. So any of function is called respiratory failure. It may be acute when it develops within minutes, 2 hours. Chronic if develops in several days or longer. So respiratory system has many components, but main is brain, that is central part. And we know that respiratory system are situated in medulla and pons. By medulla, it comes to respiratory muscles by the nerves, that is neuromuscular nerves. The brain to nerve, and it stimulate our respiratory muscles. So it contain respiratory muscles, diaphragm, and chest wall muscle. When in contract, it causes inflation and deflation of lung. So by contraction, inflation, and then deflation. Inflation and deflation. While inflation, it takes air from environment to alveoli. And for deflation, it removes carbon dioxide from alveoli to environment. So this is function. This is called ventilation. So by ventilation, it taking oxygen inside the lung and removal of carbon dioxide from alveoli to environment. So in one breath means one inflation and deflation. How much air is going inside? That is called tidal volume. So normally tidal volume is 500 ml. Means each breath individual is taking 500 ml. But this 500 ml is not reaching to alveoli. Means there is loss somewhere. The amount which is reaching to alveoli is called alveolar ventilation. So where this is loss? This is loss in airways. See, this is airways, and here is alveoli. So 500 ml it's going inside. So it is lost here, it is lost here, lost here, and around 350 ml is reaching to alveoli, which is take part in gas exchange. So you understand that alveoli has blood vessels. So CO2 is coming from blood vessel to alveoli and oxygen is coming here. So the amount of air which take part in gas exchange at the level of alveoli is called alveolar ventilation. And remaining air is called dead space ventilation. So the amount of air which we are taking in one breath is tidal volume. The amount of air which takes part in gas exchange is alveolar ventilation. The remaining which is got wasted because it is not taking part in gas exchange is called dead space. So normally we are taking breath at the rate of 12. So how much mid ventilation? 500 ml into 12, that is 6 liters. How much alveolar ventilation? The 350 ml into 12, that is 4.2 liter. And remaining air 1.8 liter is dead space ventilation, means there is no gas exchange. So what causes the respiratory failure if any problem in brain is not sending signals to respiratory muscles. So what's the cause for that? Either we are using sedative, means brain is not sensing what is happening in respiratory system, so not sending signal properly. Any CNS disease like encephalitis, stroke, tumor, etc. So these condition makes brain unable to send signal to respiratory system. So any problem in nerves and neuromuscular transmission is ALS, botulism, Guillain-Barré syndrome, myasthenia gravis, polio. So in this there is problem in neuromuscular junction. So this is muscle and this is a neuron. So any problem in neuromuscular junction. So what happens? The signal is coming from brain but not reaching up to muscle. So it causes ventilation failure. Another is problem in either respiratory muscles, diaphragm, or chest wall muscles, like flail chest, trauma in chest wall. So the rib cage is not functioning well. Kyphoscoliosis, hyperinflation, obesity, diaphragmatic paralysis, muscular dystrophy. Means there's problem in muscle. So muscle is not taking part in ventilation. Muscle is not contracting chest wall. So lung is not getting deflate or inflate because of muscles. That causes ventilation failure. Then lungs. Any problem in parenchyma. So anything which causes type 1 respiratory failure will ultimately lead to type 2 respiratory failure. And now question is, what are the causes of type 1 respiratory failure? Is like dead space ventilation, and there's ventilation but no perfusion. That is called VQ mismatch. VQ mismatch cause type 1 respiratory failure. Hypotension, diffuse limitation means air is coming up to alveoli here. Air is coming up to alveoli but not reaching to blood vessels. Why? Because there is thickening of alveolar membrane. So this is called diffusion limitation. Right to left shunt means blood is coming, so blood is coming but not taking part in gas exchange. Means problem is here in alveoli. So what will happen? Blood will come deoxygenated and return also deoxygenated. So coming deoxygenated, return deoxygenated. This is called shunt. Then reduce inspiratory oxygen tension means, say for example, high altitude, there's lack of oxygen in environment. So oxygen not the environment, so lung will not take in oxygen, enough oxygen. It will called type 1 respiratory failure. So persistent of type 1 respiratory failure will lead to type 2 respiratory failure in subsequent of time. So you understand? Now coming to our case. So this is gentleman of 70-year-old male is known case of COPD. He is chronic smoker and COPD for 20 years, but he is not taking regular medication. Whenever he was having breathlessness, he was taking medication. Otherwise, he was not taking any medication. Now he has come to ER, emergency medicine, for increasing breathlessness, cough, and fever for 3 days. And on examination, this bilateral reduced breath sound and diffuse bronchi. So what do you think? What could be the case? So when we did AVG was showing acidosis. So any pH which is less than 7.35 is called acidosis. PCO2 is high, more than 40. So this is type 2 respiratory failure. And you can see there is hypoxemia also. So usually type 2 respiratory failure occurs along with type 1 respiratory failure. So a old man with smokers known as COPD came with type 2 respiratory failure. So this is case of acute exacerbation COPD with type 2 respiratory failure. Now question is, What is the mechanism of breathlessness in COPD? So, if you remember your UG days, MBBS days, so we were taught that in COPD, because of excessive smoking, alveoli are hyperinflated. So these are, say for example, these are alveoli. What happened in COPD? This wall get damaged, interalveolar septa. So there is damage of interalveolar septa. Because of that, there is hyperinflation of alveoli. Can you see this one? This is abnormal. This is normal. This is normal alveoli. This is abnormal. Can you see? The breakage of interalveolar septa. It causes emphysema. So, two problem: airway obstruction because of bronchoconstriction COPD and emphysema. And emphysema in later stage, what will happen? Diaphragm will flatten. So, normal diaphragm is like that. But in COPD, diaphragm is flattened. So, what will happen when diaphragm is flattened? So, it will not expand properly. So, there is problem in inhalation and exhalation. Means normally this diaphragm. So while inflation, it get like this: inflation, deflation, inflation, deflation. But when diaphragm is flattened already like this, so it cannot expand further while inspiration. So that is called mechanically disadvantage. So there is low tidal volume because diaphragm is already flattened. It cannot accommodate more tidal volume. So it will cause low ventilation. When lung is not getting enough ventilation, what will happen? To meet a metabolic demand, respiratory rate will get increase. When respiratory rate can increase, there will be increased dead space ventilation. Now you can understand because of high respiratory rate, there is increased dead space ventilation. Can you tell why? See, normal, say for example, normal tidal volume is 500 ml. So dead space ventilation is 150 ml, and alveolar ventilation is 350 ml normally. But when respiratory rate is high, means patient is getting low tidal volume. Now tidal volume is 300, and dead space ventilation is 150. So how much alveolar ventilation will remain? 150 ml. So you can understand by decreasing tidal volume, the dead space ventilation get increased. Here is 150. Here's also 150. But you can see that reduction in alveolar ventilation. So because of high respiratory rate, there will be increased work of breathing. Patient will get tachypnea. And what will happen? Muscle fatigue will be there, and patient will use accessory muscle action like this scalene, as diaphragm, this abdominal muscle. And what will cause? It will reduce the ventilation, and patient is not able to get enough oxygen, and patient not able to expel the carbon dioxide. What will happen? There increase in PCO. So remember, in COPD, because of low tidal volume ventilation, patient not able to remove the carbon dioxide from the mixed unit blood. That will cause type 2 respiratory failure. Another problem is that in severe COPD, there is concept of dynamic hyperinflation. What is that? In COPD, there is breakage of septa. I told you there is many septa like this. So this septa is not functioning, it's weakened. So what will happen? Patient will inhale, no problem. But while expiring the gas, the small airway will get closed. So this is alveoli. When patient is expiring, this airway will get closed. So what will happen? There will be trapping of air inside the alveoli. Okay. So air inside the alveoli at the end of expiration, it's called autopy. What's called auto PEEP? Auto because it is developing itself. Nobody is going to add PEEP. And PEEP is positive and expiratory pressure. Means patient is not able to empty his lung at the end of expiration. So in this type of patient, when you ventilate this patient, what will happen? In each breath, there will be retention of air inside the lung. So subsequent breath, you can see subsequent breath, the air remaining in alveoli is getting increased. Up to what level? Nearly total lung capacity. So can you imagine how patient is struggling to take breath? So see when you are taking breath, so I have reached up to total lung capacity. Then now you see how patient can take breath. This is difficult. So because of dynamic hyperinflation, there increase the work of breathing because patient not able to remove his air from the alveoli at the end of expiration. So what happens in COPD? Increase the work of breathing, shallow breathing, auto PEEP, low tidal volume, poor lung compliance because of flattened diaphragm, ultimately respiratory muscle fatigue, and there is ventilation failure. What happened? High PCO2 and low PO2. This is called type 2 respiratory failure. Okay. So now question is to you, what to do next for management. So now you have patients with type 2 failure, COPD patients. Now what to do? Whether you should intubate the patient, oxygen support, NIV, or observation. Please tell me the answer. Okay, so we will give NIV trial. So now question is which NIV? Because NIV are two type. One is ICU ventilator and one is portable. So preferably we use ICU ventilator because we can do monitoring better because we have monitor and see this is monitor. So we can see all parameters and additionally we can give oxygen also by this ventilator itself. And less prefer is portable ventilator because we cannot adjust the oxygen in this machine. So what is the indication for NIV? This is not for COPD but overall. So there is high recommendation to use NIV in three conditions. That is COPD, congestive heart failure, and respiratory failure in immunocompromised patient like HIV. So in these three conditions, there is strong recommendation to use NIV. Moderate recommendation means weak recommendation that we can use but cautiously in asthma, obesity, hyperventilation syndrome, upper airway syndrome, post-operative extubation, mild ARDS. But strongly against the use. We should not use NIV in front in ARDS, multi-organ dysfunction syndrome, and tight upper airway obstruction. So in these three conditions, we should not use NIV at first hand. So indication of NIV in acute as well COPD. So this is ERS ATS guideline 2017. We should use NIV in moderate to severe exacerbation. In mild, there's no study. So the recommendation is for moderate to severe exacerbation when pH is less than 7.35, PCO2 is more than 48, patient is respiratory distress, and there's tachypnea, means respiratory rate more than 24. In such type of patient, we should use NIV at first hand. So this is a beautiful meta-analysis. So they have compiled um, most of the studies and compiled and studies around 629 patients. So you can see this diamond. Diamond is left side. What does it mean? It means that there is significant mortality benefit in of NIV in patients of acidotic respiratory failure in COPD. So, COPD patient with type respiratory failure, we should use NIV. At least we should give trial. So now coming to setting, as I told in my previous lectures that in NIV we have Epep, that is expiratory positive airway pressure, inspiratory positive airway pressure, and oxygen. Okay. So what is Epep? Epep is equivalent to CPAP, means it is not letting airway to close at the end of expiration. So if you forgot, please go to my lecture on NIV, then you will understand better. So what CPAP does? CPAP is not letting airway to close at the end of expiration. Means what happened in COPD? COPD at the end of expiration, small airway collapse by which air is not coming out from alveoli and causing air retention and autopy. So CPAP is useful. Also, it decreases airway resistance. So two function. It decreases airway resistance and preventing autopy. Okay. And second setting is IPEP, that is pressure support ventilation. So how to calculate pressure support ventilation? This is just nothing but IPEP minus EPEP. So you subtract EPEP from IPEP, that will is pressure support. Means the pressure support is helping to augment the tidal volume and reducing work of breathing. So this is just rescue thing. Means COPD patient, say for example, COPD patient is able to generate 200 ml its own, and patient needs 500 ml. So this 300 ml will be provided by NIV. So this is just like a rescue. So you can see this is blue one. Blue one is the tidal volume which is patient is generating, but this one is the support which is given by NIV. So patient is taking 200 ml only, but NIV is giving 300 additional. So when patient is getting enough tidal volume, what will happen? Patient will feel happy, and the work of breathing will get reduced, tachypnea will get reduced, and patient will get wash out of CO2 because ventilation is good. Previously, he was getting 200 ml its own, but now he's getting 500 ml. It will help to remove carbon dioxide from the body, and of course, oxygen support. Because this type of patient they are used to having hypoxia also. But we should keep in mind that we should not over oxygenate this patient. We have to keep our PO2 between 56 to 60 only, or SPO2 just 88 to 92%. We should not over oxygenate this patient, it will increase PCO2. Okay, now question is which interface, nasal or oronasal? Oronasal means face mask also. We call face mask also. So the study says in acute care setting, when patient is breathlessness or came in emergency, we should use oronasal mask as a first choice. But when you discharging patient on NIV, we can use nasal mask. So remember, in acute setting, oronasal mask. In chronic setting, nasal mask is preferred. Now, why we should use NIV in acute respiratory failure? This is just summary of what I have told so far. So it is reduce work of breathing by 60%, increase tidal volume. When increased tidal volume, there will be relief of tachypnea, means decrease respiratory rate. It increase lung compliance, decrease autopy, and cardiovascular system. It reduces in cardiovascular. It increases preload. That's why increases cardiac output, and it help in oxygenation and decrease carbon dioxide. So we can leave this one. So coming to our case. So our case, the diagnosis was acute exacerbation COPD with type 2 respiratory failure. We have we have given NIV 12 by 6, means IPEP is 12 or EPEP is 6 with oronasal mask. The AVG was 7.25, PCO2 was 85, PO2 was, this is initial setting. But after 1 hour, patient become drowsy, gasping, and there was lot of conductive sounds. Means there's lot of secretion inside the airway. And you can see the AVG has worsened. pH become more acidotic and increase of carbon dioxide. What does it mean? It is sign of NIV failure. So we should be cautious to diagnose NIV failure. So what does NIV failure means? Means either there's cardiorespiratory arrest, increased work of breathing, progression of underlying disease, either severe sepsis, worsening of AVG, means increase of type 2 respiratory failure, or their clinical condition like increased respiratory rate, decreased conscious level that our patient got drowsy, hemodynamic instability, drowning secretions, uncontrolled agitations. So you have to identify these factors because it means there is NIV failure. So as a clinician, we should predict NIV failure before it happens in real. So where studies shows that risk of NIV failure is more than 70 if at the time of admission low GCS less than 11, Apache score more than 29, and there's highly tachypneic patient, means respiratory more than 30. pH is acidotic. This subset of patient, they used to have more than 70% chance of getting NIV failure. And patient is having more acidosis even after applying NIV, then this type of patient, they used to have more than 90% chance of having NIV failure. And overall NIV failure is about 5 to 40, means out of 100, 5 to 40 patients are going to fail NIV. So we should suspect NIV failure and we have to intubate that patient. So undue delaying of intubation is increases morbidity and mortality. So whenever you find NIV failure, you have to intubate immediately. You should not wait. So what are the contraindications when we should not use? We should not use when there's lot of secretions and patient is hemodynamic unstable or there's cardiac arrest or patient is not taking his breath, means apnea. So these are absolute contraindication. Relative contraindications, if patient is unconscious, non-cooperative, morbid obese, and mask is not fitting properly. So we should keep in mind contraindication also. So coming to our case, so our patients got NIV failure. Then what is the next step? We should intubate the patient and we should apply invasive mechanical ventilation. So we intubated this patient and kept up mechanical ventilation. So detail of invasive mechanical ventilation I'll discuss in next part. So I advise you to see my second part of video to complete this case scenario. So friends, thank you for this part. We will see you in next part.